Now for a deep dive into racial and social inequities that have been laid bare by the pandemic. Are we being thoughtful about the vaccine rollout? I'm joined by Dr. Margaret Moss, and she's director of the First Nations House of Learning, an associate professor in nursing at the University of British Columbia, and also Daniel Dawes, co-founder of the Health Equity Leadership and Exchange Network and director of the Satcher Health Leadership Institute. I should also say in his tweet, it's kind of going back, it's almost February again, which I can't believe, but he has a book, which I find very relevant to this, which I'm going to order. I haven't read it yet, The Political Determinants of Health. So, anybody who's got a book, bless you. I'm going to, get them all. But let me just, start with you, Margaret. I don't want to sugarcoat anything. A lot of us have talked about what might be going well, but, we do have these issues, and I've been raising them with a lot of people. I don't see the communications plan of, trusted ambassadors in certain communities. I just, it doesn't matter across the board. There is a palpable distrust out in some parts of America on these issues. Well, you are a health professional dealing with community, and a community that may not have felt like the cards were stacked in their favor in this country. How do you bridge that, and what lessons do you have for those people online listening of what we can do better?
Well, thank you, Steve. And indeed, what about trust in these areas? Yeah. For American Indian, Alaska Native populations, I know around this pandemic, there are three main issues. First of all, the infection and death rates. Secondly, practical issues. As one of your former speakers said, they could deliver to 84% of the country. I can just imagine where the other 16% are, probably in Indian country somewhere. Yeah. And then there's the trust issues. So with the first one, COVID has hit Indian country with great force. One study showed that the infection rate is 3.5 times that of whites, the death rate approaching twice as much. So right away, here's a big, huge problem. And, what do people know about it? What are they doing about it? And one of the other problems with what's happening in Indian country is people already have these underlying health problems, diabetes, lung disease, heart disease, and so forth, which makes them so much more susceptible to infection and to death. So understanding that, what do we do about when equity comes into play, they not only need what everybody else needs, they need even more of it. And unfortunately, that doesn't happen. So why is that? Well, in Indian country, there are great distances, lack of water, multi-generational households, low access to health care, et cetera. And it's decades and decades, approaching 100, 200 years of federal Indian policy that put people where they are, how they're living, what resources they have and don't have. So that's where the trust issue comes in. When you've had those policies of removal, reservation, termination, assimilation, and so forth, why would you now suddenly take the government's word for, the distribution, the safety, and so forth of what's happening? Another problem is there's no good numbers. The numbers we do have are probably highly underreported or undercalculated because of misidentification. A lot of people don't realize that now 78% of American Indians are off reservation. And once they leave in so-called Indian country, often they are not identified as American Indians. So the rates could be completely off. So now when we get to this trust issue, and the practicality, I know from my own tribe, which is in North Dakota, I read stories all the time of elders going these great distances over ice. This is North Dakota. And when they get to the destination, the product is not available and they're turned away. So huge problems. So with the trusted messenger idea, in Indian country, largely it will be elders. Elders have a certain status, but also grandparents, just by virtue of being older, knowledge keepers and language speakers. I know one young person who said when he hears it in the language and from an elder, that's when he'll get the vaccine. But mind you, an Indian isn't an Indian, and you run the gamut of, yes, of course I want the vaccine. How do I get it? And you might have the practical issues too. I don't quite trust it, so I don't think I'm going to do it. The problem with the older people being the messengers, the ambassadors, the trusted people, is that in the US, largely 16%, almost 17% of the population is over 65, but in Indian country, it's already only 9%, and due to those, in large part, those federal policies. So trust should have been developed before this problem. It's kind of hard to develop on a dime. But again, there are people that will trust trusted health professionals, as somebody brought up before. So getting the word out, showing that it's safe, and it's so needed because of the desperate numbers. And then the trust has to be ongoing. There has to be complete development, as you were saying before. There has to be communication plan. There has to be, ambassadors and so forth.
Well, thank you for that. Daniel, I think Margaret has done a very eloquent, comprehensive job of looking at where we really are: distrust, unevenness, lack of equity. And I don't think we should have any illusions. President Biden, my computer was popping all day with more executive orders and statements of, the commitments and public. So we're like right at that moment where we're coming in. But I guess my question is, because I know you're an expert in it, I don't think a vaccine rollout necessarily is going to solve civic justice, racial justice issues that have been baked into this country right away. But what do you have to tweak at this moment of national emergency so that you're not only responding to national emergency, but that we begin to tilt the right direction when it comes to equity and civic justice?
Yeah, I really appreciate that, Steve. And let me just add that, when we think about the moments of crises in this country, we've been able to realize some equitable responses, usually during pandemic or actually natural disasters, wars, depressions, recessions, but never during pandemics or epidemics. So never before in the history of this country have we been able to achieve an equitable response during a pandemic. And I believe that the trend has to stop now. What I can say is that you are absolutely right. I think we've all had our eyes on the 100 million vaccine doses that administered number as a significant milestone. So we know there's 100 million as a milestone for the Biden administration. But I'm more interested, in the number of vaccine distribution sites located in lower socioeconomic status neighborhoods, or the number of mobile vaccine vans being dispatched to rural areas. So in terms of an equitable response to this, you're absolutely right. Margaret made a compelling argument highlighting what some of these issues are, these inequities. Now, I'd just like to quickly add why we are doing that. So as we are, of course, trying to address the immediate pandemic issues that are striking, we also need to look further upstream and address those upstream causes that have created this. So we know that health inequities in this country have been documented for decades. They've continued to persist for decades, right? And become so entrenched in our structures, in our systems, institutions, and communities. So what do we do about that, right? Now is the time to address those underlying factors that insulate and perpetuate these health inequities. We've been talking about returning to normal. What does that mean for these disparately impacted communities? If normal means prior to the pandemic or during another era, that's simply not acceptable for these groups who will, after things get back to normal, will continue to suffer discrimination and disparate impact.
Do you think there are ways, I want to ask it both of you, how do I put this? I try in our programs that are here to get people that are, excuse the language, real. I had a woman on the show recently who was having a lot of health challenges, and she's in the greater DC area, and she has a number of chronic conditions, and it was a program on healthcare and what was going right, what was going on, what telehealth did. It had a lot of dimensions. We just realized this was a very, very good person with a lot of stuff that she was dealing with. And I asked her on the question of vaccines and whatnot, how many of her family members, she had a big family, how many neighbors would be lining up for the vaccine? And she said almost none. She said she wanted it, but almost none. So, when you go into a community like, I hate to judge either one of you. You're both pretty connected. You both have jobs. But if you go into a community where it's not as easy, they're not all tuned into, the Hills program on the challenge of our time. It's just different. I don't know. I don't want to be silly about it, but I don't know how to get into that area or how you turn that into a government policy program without some of the things that Margaret talked about, which are trusted advisors who just make this obsession to go into those communities, Daniel, as you just said. So do you have any thoughts about that? Because sometimes I think we need to get a reality test that our, nifty, swift, kind of slick talk isn't really the real world for a lot of people. Daniel?
Yeah, I totally agree with you. I think, so I'm located in Atlanta, Georgia, work for Morehouse School of Medicine. We work a lot in the African-American community. And I'll tell you that, even in recent news reports, looking at what's happening in California, for instance, right, looking across cities in this country, African-Americans have a huge distrust of the government and of our healthcare system. And I think rightfully so because of the decades, right, and centuries of oppression in those systems. So I would say that, one of the things we've been working on, and I've been talking to folks in a multi-sectoral fashion. So speaking to those in pharma, speaking to those in our healthcare system, public health leaders and others, trying to understand what are they seeing. And I'll tell you, in terms of one statistic, I know that for some pharma companies, a large number, in fact, one stat that was shared with me from Mass Bio out in Boston, basically stated that 70% of the African-American employees would not take a COVID vaccine, and they work for these pharma companies. We know that when you look across the board, the National Medical Association, looking at Black physicians, about 60% of them in the fall said they would not take the vaccine, and they could not recommend it to their patients. And about 40% of Black nurses were saying the same thing too. So we know, coupled with that, yes, there is the anti-vaxxer movement, but there are also groups within the Black community that have been pushing a false narrative about the vaccine. What we are trying to do is to ensure that we push back on that misinformation. We are sending out our messengers, our physicians who have been anchors in the community, who are trusted, to say, look, we have had people there at the process from the very beginning, myself included, others, our president of Morehouse School of Medicine and so forth. We've had scientists who've been involved in the process. They have been there from day one. Many of them have been involved too in creating this vaccine. We have made sure to include in the clinical trials African Americans. So we know the impact of this. So there's a whole host of things that we're working to overcome that distrust and mistrust. But it does take time, and it really does take not only a trusted messenger, but trusted messages, right?
Thank you. Margaret, I want to get a quick question in here, but I want to give you an opportunity to answer that. But, as I listen to you very visually talk about the elder going across the ice, going to go to the vaccine, not being there, I don't know whether that should go on a TikTok video or whether it should go on social media, but, that story needs to be told. Sometimes you did just share it, but I'm just thinking that there are a lot of issues out there that don't get the treatment out there. So, maybe TikTok's not the right place, but, the one I think, it is an interesting communications challenge to let people in to see the anguish that they're experiencing in real terms. But your quick thoughts on this, and then I want to jump to a question to both of you.
Sure. There's a huge invisibility of, I hate to use that, it's overused in American Indian world, but of American Indian Alaska Natives and their issues. Rarely do you see anybody on a panel, so thank you. Rarely do you hear any of the issues, whether it's the missing and murdered Indigenous women and girls, they're killed at 10 times, murdered 10 times the rate on reservations as any other group. Do you hear about that? The issues are just astounding and deep, and yet they're almost never reported. Maybe once a year, a major newspaper, they might do some, jump in and jump out type of thing. But people just don't know. You're right, they don't know. And the way I get most of my information about deaths and missing and so forth is through social media. It's, in Twitter, it's in Facebook, almost never on widespread public media. So people don't understand that this problem is so as big as it is.
Well, I'm going to invite you both back a lot so we can kind of keep this going and not make it like a one-time deal. But let's take a question from Gina. Gina?
Hi, I'm Gina Fitzgerald, and I'm Director of Strategic Communications for SAFE Project, and we're a nonprofit based in Arlington, Virginia. The COVID-19 pandemic collided head-on, as you know, with the existing substance use epidemic last year. Just like patients with other chronic diseases, such as diabetes, people with substance use disorder or who are in recovery are also at increased risk for COVID. So why were people with substance use disorder, known to be a chronic disease, not prioritized to receive the vaccine?
Well, I'm not sure you're responsible for them not being prioritized, but thank you for that good question, Gina. But your thought, Daniel?
Oh, Gina, thank you for that question. And it is certainly an area of priority for us at Morehouse School of Medicine at the Satcher Leadership Institute. It is one of the reasons why we are creating a health equity tracker that not only is going to track health inequities relative to these chronic conditions such as lupus, asthma, diabetes, et cetera, but we were intentional to make sure that we are including these factors. So we're going to be tracking addiction-related inequities. We will look at anxiety, depression, suicidality, and Alzheimer's, right? Because we believe, just like Patrick Kennedy, that we all need a checkup from the neck up, right? The brain is an important organ, and these diseases of the brain are just as critical. So you will see that in April, we are going to launch a tool, and Dr. Moss has been a part of this effort, a national tool that will track these inequities from COVID-related inequities and how they intersect with substance use disorders and mental health illnesses. So we're pretty excited about that, and we hope that it will shed greater light on an area that is really stigmatized still and treated as a secondary issue, right? Not as prioritized as we know as the other chronic diseases.
Well, thank you. Your quick thoughts, Margaret?
Well, across Indian country also there's the medicine wheel, which is the 4 domains of the person. We've spent a lot of time on this show talking about the physical aspects. So the other ones are spiritual, emotional, and mental. And those ones are huge across Indian country because of historical trauma from all of the ills from policies and so forth. And it is those ones that lead to alcohol use, substance abuse, which is unfortunately pretty big across Indian country as well. And then it's colliding, with today's issues, including the pandemic. So it's not a either or, it's a both and all have to be taken care of.
Well, listen, this has been a terrific conversation. Dr. Margaret Moss, member of the Hidatsa Dakhóta tribe and director of the First Nations House of Learning, associate professor in nursing at the University of British Columbia. I've been there, beautiful place. And thank you so much. Daniel Dawes, director of the Satcher Health Leadership Institute and executive director of health policy at the Morehouse School of Medicine. Really hope you'll both be back. Thank you. What a day. What a day.
Thank you, Steve.
And I feel like, we moved in the notch a little bit, on some of these issues, but I realize it's tough. But thank you so much for being part of this conversation.
My pleasure. Thank you.